Yesterday, I had the great privilege of coming to this podium for my talk, just a few speakers after a Nobel Prize winner, which studied hypoxia in kidney cancer. For that, he deserved the honor of being recognized with the Nobel Prize. Today, of course, is a completely different environment, but still it is a privilege for me to be here, because beyond all the science, beyond our ambitions, our career, beyond all the economical considerations surrounding healthcare, at the end of the day, we are here to serve you with our minds, with our souls, and with our science. First of all, I want to introduce myself a little bit. I'm a medical oncologist dealing mainly with kidney cancer. I live and work in Pavia, which is a small university town in the northern part of the country, close to Milan. These are some snapshots of my hometown. And I work in this university, one of the oldest universities in the world. And fortunately enough, we were able to upgrade our facilities recently. These are my disclosures, and once again, I have to highlight the fact that we need pharmaceutical companies in order to develop novel treatment for all of you. So I'm not going to show you many survival curves, nor to discuss absolute values. I'm going to show you a few notes that I put on the slide yesterday night, like preparing to face my patients in my office every day. So a few considerations on second-line therapy. When I start talking to a patient about second line, it's because first-line therapy has failed, or at least has stopped doing its job, that is controlling tumor progression. This is always a tough moment for a cancer patient, like the entire world is on the edge of falling on his or her head. But for the vast majority of you, fortunately enough, this is not true. This is just an unpleasant but obliged step in your personal war against cancer. You have to keep in mind that very few individual agents proved able to impact on overall survival, which still is the golden endpoint for us as medical oncologists. Indeed, sunitinib, pazopanib, sorafenib, the combination of bevacizumab plus interferon, axitinib, everolimus, lenvatinib plus everolimus, avelumab plus axitinib, all proved to be active agents or combinations which yielded just a progression-free survival benefit and not an overall survival benefit. Very few agents, temsirolimus is a niche of patients, ipilimumab plus nivolumab and pembrolizumab plus axitinib were able to really prolong the per se overall survival. And in second line, it was the case for nivolumab and cabozantinib. But since metastatic kidney cancer patient survival has greatly improved over the years, it is clear that any overall survival benefit is achieved and is achievable by means of a sequence of active treatment, not by a single agent. This is a typical example. You receive first-line treatment for a certain period of time, then go on to receive second-line treatment, third line, and the number of patients progressing through several treatment lines is fortunately increasing, meaning that we are able to select a growing number of long survivors, because the number of patients receiving more than 2 treatment lines is increasing. And ultimately, this is the path towards a prolonged survival. Unfortunately enough, this axiom from Tom Powles, a good friend of us from UK, is no longer necessarily true. He spoke about a law of diminishing returns, meaning that moving from one treatment line to another, you lose something in terms of months of survival. This is no longer true. we have so many active agents that we can imagine to give to you all of these agents, ultimately prolonging in a really significant way your life expectancy. And immunotherapy plays a peculiar role in this long path towards our fight against kidney cancer. This is probably the only curve I'm going to show you. Just to remind one thing that one of my mentors in the field of kidney cancer told me. He was the late Professor Peter de Mulder from the Netherlands, who fought for his whole life kidney cancer, first as a physician and finally as a patient, and ultimately succumbed to kidney cancer. And he used to say that oncology is a matter of tails, meaning the tail of survival curves. Because if we compare immunotherapy, any given immunotherapy agent you want, with a standard treatment within a randomized controlled trial, at the very beginning you see no separation at all in survival curves, meaning that there are patients who are not going to respond to either the standard treatment as well as the experimental arm, the immunotherapy agent. But later on, we are able to observe this kind of separation in the curves. This is where survival impact occurs, and median overall survival is increased. But more importantly is what happens here in the tail of the curve. We start to observe with immunotherapy a survival plateau, meaning that a growing number of patients is achieving a long-term benefit, and possibly some of them are cured. Our goal today is to try to improve the number of patients reaching this plateau, hastening the height of this plateau, as it has already happened in the melanoma field, where presently we are able to select as many as 50% of metastatic melanoma patients. This is not still the case for kidney cancer, but we are improving, and this should be our personal goal. There is a universal rule, in my opinion. Not every physician are equal, but all cancer patients are, because they simply want to live longer and possibly better. Whatever better means to each of you, for sure, better is something that is hardly captured by typical quality of life questionnaires. And this is why we are presently developing and validating at a global level patient-reported outcomes, which probably will translate in a better way your feelings, your thoughts, your everyday living to us in order to improve the way we are curing your disease. Another rule is that the trade-off between benefits, for example, survival gain, and harms, treatment-related adverse events, a typical second-line kidney cancer patient is willing to accept is often different as compared to that usually accepted by a newly diagnosed patient. Safety and quality of life are usually more important in later treatment lines, although, of course, this is not a universal rule. This means that the treatment experience of each given patient is key in order to select second line of treatment. Just an example, if a patient has experienced huge toxicities, and you know what I mean better than me, then a more gentle agent would probably make more sense as a choice for subsequent treatment. Taking into account that RCC remains an angiogenesis-driven disease throughout its whole natural history, meaning that after the failure of an anti-angiogenic agent, another one can be active and continue to control disease progression. This is a truly paradigm shift from the era of cytotoxic chemotherapy, when a given class of agent failed. Then it made no sense at all to select another similar agent, because the chances of continuing to achieve benefit were extremely low. This has changed. This has changed especially in kidney cancer, due to the fact that this was the very first tumor, the very first malignancy in which targeted agents proved to be active, even before immunotherapy. One of the greatest issues is the issue relative to disparities. Disparities in the access to active anti-cancer treatments across different tumor types, of course. It's not just a problem in the field of kidney cancer. This is something patients have to face independent of the tumor, of their tumor, lung cancer, melanoma, colon, whatever. And these disparities are geographical, social, and racial, depending on the place you live, depending on the country. And I'm going to show you some of these slides that Cora Sternberg yesterday presented at the scientific meeting. Cora is a good friend of us, an American lady who moved to Italy, who operated as a physician, as a well-known oncologist in Italy for several decades, and then came back to New York later this year, probably, in order to continue her job. And she showed these slides. This is the geographical distribution of oncological centers enrolling patients into clinical trials. And it is clear that both you, as well as us, as Europeans, are very fortunate, because we can offer our patients the opportunity of entering clinical trials of those novel agents that ultimately improve so much your life expectancy. But the situation is extremely variable across the different continents. As you see, there is very few centers enrolling in South America, very few centers enrolling in Middle East, at a certain extent in Asia, nothing in Africa. This is a huge disparity. And this is something that occurs also at a local level, probably being treated in a small community hospital somewhere in, Louisiana, or maybe in Puglia in Italy, is different as compared to coming to Philadelphia or coming to my place. This is a disparity. Also because the distribution of centers enrolling patients to clinical trials does not align with the burden of kidney cancers. As you can see, Africa has not such a huge incidence of kidney cancer, although probably it's a matter of underdiagnosis. But still, there are very few centers doing clinical research on this disease. And more striking is the situation in Asia. Asia has a high incidence of kidney cancer, but ultimately the numbers of academic centers or research centers doing clinical trials offering novel treatment options to their patients is extremely low, as compared, for example, to America or Europe. And this is another key point. An equal distribution of clinical trials is strictly related to the income of that given country. People come from high-income countries, have more opportunities. Also in countries like Italy, where all medications are free for everyone. And a group of colleagues of mine clearly showed that despite this fact, Take in mind, in Italy you can receive almost every drug registered and reimbursed free of charge. Despite this, they proved that an economical toxicity is present. They demonstrated that those patients that needed to move from their home to receive an experimental treatment in selected centers had a reduced survival, despite being treated with the best treatment possible. This is some kind of economical toxicity we should take into account when speaking about treatment opportunities. And also, in a country like Italy, which is a fortunate country, we are recognized to be one of the best health systems in the world. We still have issues. We still have disparities. This is a comparison of what is available presently in first treatment line or in more advanced treatment lines in the United States as compared to Italy. And as you can see, the number of active agents we can give to our patients is lower as compared to the situation in America. Why this? Because we are struggling to make all these agents really available because they do cost a lot, and the discussion about the reimbursement is something that unfortunately prevents for an average time of more than a year to give our patients any possibly active agent. So I want to conclude. Of course, I did a very short talk, was 30 minutes that Naomi assigned me, but I think that I tried at least to tell you something that I used to discuss every single day with my patients. And so to conclude, I want to believe. I want to believe the possibility of increasing your life expectancy. I want to believe to increase your quality of life. I want to believe that we are able to cure at least a certain amount of you in the near future. This is something that we can really achieve. We have to continue to work together, and fortunately enough, these 2 days of cooperation between Italy and Philadelphia were a good example of this. And I think that this is the right way. And I think that your efforts, also your pain, your struggles, will help other people in order to make the lives of those who will suffer of this disease in the near future better, and probably to offer them better care and possibly better cure. Thank you very much for your attention.